Top Med Talk.
Today's Top Med Talk is about the COVID-19 crisis. This piece was recorded last year. However, we still believe it contains lots of useful information. Have a listen.
We're going to dive into management of the COVID patient with our next guest here.
Okay, my name is Manuel Ignacio Monge García. I have two first names. I work in the ICU in the south of Spain in Jerez de la Frontera, at the Sherry place, Sherry wine, motorcycles, it's a very well-known place. And I have been mainly focused on hemodynamic monitoring research and cardiovascular physiology during the last 10 or 15 years.
You're a household name to those of us who are interested in the hemodynamic monitoring space. None of some privilege to hear you lecture and have met you personally before. Now, you have a few pet areas within there that you've been a driver in developing. Do you want to touch on those just briefly?
Well, I've been focused mainly in arterial system physiology, but at the same time, I've been trying to connect the arterial system physiology with the cardiac function and trying to get the ventricular arterial coupling physiology to the critical care setting.
And you use that regularly on the bedside? Because your lectures imply the fact that it's every day of the week for you.
Well, personally, I did, but I try to combine my colleagues, and it's quite difficult to do that because first thing, we have to admit that it's a complex concept, and trying to explain the ventricular arterial coupling and how to apply at the bedside could be very difficult. But I think it's an interesting concept. It's a very well-known concept in other fields, and I hope that it will be accepted on the critical care.
Ignacio, can you give us just a little bit of background about the size of your hospital and the size of the ICU that you work in?
Well, my hospital is a medium-sized hospital, 500 beds. My ICU is a surgical and medical ICU. We are treating mostly medical patients. We have 20 beds for ICU patients, but during the last weeks, we have to increase the number of beds for covering the COVID patients. So at this moment, we have mostly COVID patients and only an isolated ICU for non-COVID patients.
We've heard a lot on the news over here in the U.S. that Spain has seen a major surge. The trajectory has been very similar to the U.S. and the U.K. Can you speak to that a little bit? Are you seeing that in your area or is that in other areas in Spain?
Spain, in a general view, has a similar pattern that Italy, but probably we saw a differences in the north and the south of Spain. We don't know exactly why. But we suspect that the weather and the density of population will take, for example, Madrid and Barcelona have a lot of patients and they have been overwhelmed by the number of cases. But we saw an increasing number of COVID patients during the last weeks, but never at the same level that the north of Spain.
Talk to us a little bit about the management of these patients. Obviously, when they get up to you in critical care, they've been through the emergency room and, they've gotten up to you. They obviously are having escalation of care. And kind of just to break it down, like in the ABCs, airway, breathing, circulation. When it comes to airway, are you opting for early intubation or are you trying to keep these patients off the ventilator?
Well, the first thing that we have to say is we are very lucky because we have the knowledge from people, from the Italian doctors and Chinese doctors. So they put the alarm and we have time to be prepared. And that's an important thing to thank for because we have time to prepare our protocols. We have time to prepare our ICU to admit all of these patients. So we prepared protocols for intubation, for the respiratory management, hemodynamic management, everything. We try to be prepared. And probably that's the only reason to be prepared was the advices from the Italian and Chinese colleagues.
Are you doing a lot of proning? Are you flipping patients over onto their front? We've done lots of locally because we've heard that has helped a lot.
Yeah, at the beginning, we put all the patients on prone positions. We try to decide if we should continue with the prone position depending of the oxygenation. But you know that the things are changing during the last weeks with the two phenotypes. And we started to think that probably the prone position is not the right treatment for patients with the normal respiratory compliance or nearly normal respiratory compliance. And we should keep that treatment only as a rescue therapy. But this is a learning curve. We are learning during all days. We have the recommendation that are changing a lot during the last days. So at this moment, we cannot recommend one thing, because probably the next day it will change.
Just practically on that front, it's very physically demanding. It's demanding for manpower. We know historically that the patient who is face down when intubated and ventilated is much more challenging to manage. There are issues with pressure points, etc. But there's also, as you say, as we learn more about the biology of it, it seems to be the lungs, but in some patients also the kidneys that become under attack. And lying face down is not necessarily good for your kidneys either because of the pressure consequences of that.
Yeah, it's a good point. Honestly, I think that probably one of the main reasons for the impairment in the renal function could be related to our hemodynamic management of those patients. We try to do the same thing with the ARDS patient, with patients that are not ARDS patients. I mean, we saw patients with chest X-ray, normal chest X-ray, or almost normal, but we try to keep those lungs dry using a lot of diuretics or trying to reduce the intake of fluids. And probably that kind of management could impair the renal function. And I suspect that part of that impairment on the renal function is due to our hemodynamic management.
And so I've just been watching the European Society of Intensive Care Medicine webinar recording on acute kidney injury. And in the first lecture, that comes through very clearly that people have said, well, hang on a second. Although it is ARDS of a form, it is an acute lung injury. It's not like many of the patients that were in the ARDSNet studies. And on reflection, they came in probably very dehydrated and therefore probably needed both resuscitation, replacement, and hydration. So we sort of backed off to resuscitate and then, like everyone, try and avoid excess water and salt.
There are a lot of reports of hemodynamic instability of these patients. And just speaking to what you guys were saying about the proning, that has consequences. I mean, there are a lot of things that we're doing to these patients that could potentially be causing iatrogenic hemodynamic instability versus is being caused by the actual illness. Can you speak to that a little bit about management of these patients?
Well, for example, I think that the main hemodynamic problems in the COVID patients are related to, first, the hypovolemia that we could create with the conservative feeding strategy, but also with our ventilatory support. I mean, if we try to use high level of PEEP with patients with a normal respiratory compliance, we are impairing the preload of those patients, and we could probably decrease the cardiac output. But the second main problem could be the vasoplegia that we can create with the high level of sedation that those patients require for being adapted to the mechanical ventilation and prone positioning. And also, we saw a lot of secondary bacterial co-infection that could affect to the vasoplegia. But as you know, there is a lot of patients with a high troponin level, and it has been related with a cardiac dysfunction. So I think it's a mix of hypovolemia, vasoplegia, and cardiac dysfunction. And probably in the latest stages, we could see an increase in right ventricular afterload due to the prothrombotic state and the change in the pattern of the respiratory mechanics of those patients.
So you're saying you think a hypovolemia because they're coming in dry because they've been sick days up until this and not taking adequate fluids and febrile. It's a vasoplegia. So it's actually, you said causing from sedation from us. So the things that we're doing to help mechanically ventilate them. And also like a septicemia. So something that's caused because they're sick as well?
Yeah, exactly. The secondary infection in those patients could be the reason for the vasoplegia too.
Yeah. And then cardiac dysfunction related to, again, what we're doing.
Exactly. Okay. And the virus, because there is a direct effect of the virus on the cardiac function. It has been related to high levels of troponin, and patients with a higher levels of troponin have a worse prognosis.
So a direct attack on the heart and possibly the kidneys, as Monty said too.
Yeah.
So Ignacio, a very common thing I've heard from lots of my colleagues, friends, people I've interviewed who are a number of weeks into this now. They say on reflection that if at the beginning they kept it simple and they had done what they usually do, airway, breathing, circulation, and when it comes to circulation, get their monitoring on and deal with preload, afterload, contractility, and then think about hydration, they're suspicious they might have been in a better place now, and that the sort of, ARDS label being the sort of classical ARDS may have set them back a couple of weeks.
Probably if we are changing the concept of how this virus is affecting to the lung, we should also consider to change the approach in terms of the hemodynamic monitoring. It's not a matter of trying to keep the lungs dry or wet. It should be to keep the right amount of fluids and try to use those parameters from the hemodynamic monitoring to give fluids when it's really necessary. So that should be the first step at the beginning. You don't know if this patient has a wet or dry lung, but you should try to keep the amount of fluids in the between line. You should not try to keep the lungs dry, but not wet. And the only way to do that is using hemodynamic monitoring. You can do that using diuretics or giving fluids without any rationale or only because you think it's the best treatment for that patient. I think it's very useful in this context, the hemodynamic monitoring.
Walk us through when you're looking at these patients and what do the parameters look like when you first put a monitor on these people who may not have been resuscitated?
Surprisingly, we saw normal levels of cardiac output. We didn't see low cardiac outputs or situation with low cardiac output. Actually, we saw normal levels of cardiac output, normal levels of lactic acidosis, or normal levels of venous oxygen saturation. So it seems that those patients with a normal respiratory compliance has a different pattern than patients with the ARDS pattern. So we should be very careful to try to do the same thing with all patients. If we are going to change how to treat the patient with our ventilatory support, depending on two different phenotypes, we should also think that we probably will need to change our approach in the hemodynamic management, probably depending on the respiratory pattern too.
Theo, did you see a change whenever you had these patients and you were going up on their levels of PEEP and pressure support and things like that? Were you seeing a drop and changes in their dynamic parameters?
We saw changes, but probably the reasons are absolutely different. I mean, it would be absolutely different if you try to increase PEEP level in a patient with a normal respiratory compliance, because the effects on the preload and afterload will be different in a patient with a stiffer lung. So probably the patient with normal respiratory compliance, the impact will be higher in the preload, also in the afterload. But in patients with the ARDS lung, increasing PEEP level could have two effects. If you are able to recruit the lung, you will see probably an improvement in right ventricular afterload. But if you increase the PEEP level and you are not able to recruit the lung, you probably increase the right ventricular afterload and you are going to impair the right ventricular dysfunction. So in both patients, you could see a decrease in cardiac output, but the reasons are absolutely different.
What about fluid responsiveness of these patients in doing, fluid challenges and things like that? Is that something that you've employed?
Yes, I think it's important to use those parameters over the statics parameters. Always try to use the dynamic parameters, but at the same time, it's important to remember what are the limitations of those parameters. If we are going to ventilate those patients with low tidal volumes, or if those patients have a low respiratory compliance, we should remember that the reliability of those parameters are not good. So probably the threshold and the sensitivity and specificity of those parameters are not exactly the same that in patients with normal and healthy lungs. So it could be helpful, for example, to decide if we should give fluids or not, but always keeping in mind those limitations. It's not only the PPV or SVV, the pulse pressure variation or stroke volume variation. We have all others maneuvers, for example, the passively raising. And even you can try to do the passively raising, a modified version of the passively raising in patients in prone position, because the only thing that you have to do is to change the position of the patient with the bed down, and you can check the increase in the cardiac output. So it's easy to do at the bedside. If you have a monitor to check the change in cardiac output, that's the most important thing.
Our institutional algorithm has that as an objective at the front end. One of the challenges is when people are so busy and so overwhelmed that we would normally regard as every day at the office, measure cardiac output, measure stroke volume, do fluid challenges, starts to become overwhelmed. So we have to work out a way of selecting the patients that need the more meticulous management, because good hemodynamic and fluid management is rocket science. It is complicated. Now, that having been said, let's take it even more complicated You're very well known for research about dynamic arterial elastance. Now, we're not going to do a deep dive on that at the moment, but just very briefly, what is it, and are you finding it useful at the moment?
I never tested the usefulness of dynamic arterial elastance in COVID patients. I checked the trend changes on dynamic arterial elastance in COVID changes, and I guess that the usefulness of this parameter could be probably the same in COVID and not COVID patients, because the rationale for this parameter is relating the changes in pressure over the changes in flow. So you can check how the arterial pressure changes with changes in flow. So you have a picture of what is the relationship between both. It's a more complex parameter than saying that it's a dynamic index of the afterload, because it's related to the ventricular arterial coupling, because we published very recently a paper about that. But practically speaking, the dynamic arterial elastance is going to say to you, if you have to give fluids because the patient is hypotensive and is preload dependent, dynamic arterial elastance is going to tell you if that fluid is going to increase arterial pressure or not. That's easy.
So this is probably not the moment for people who don't know about dynamic arterial elastance to get into it. But in the wake of all of this, there's a learning opportunity there, and it's a cool subject area, and thank you for your contributions in that space. But I'm guessing at the moment it is try some fluid challenges to optimize stroke volume, think about the mean arterial pressure, worry if the heart's beating okay. Is that about it for now? Yeah, you're right, absolutely. Well, I think it's important to remember that the management of those patients is not only respiratory management. I think it's important to remember that our ventilatory support will have effects on the hemodynamic status of the patients. And the only way to check what is the impact of those respiratory management is checking the changes in cardiac output blood pressure. And we should use the hemodynamic monitoring. But I think it's also important to remember that the information coming from the hemodynamic monitoring could help us to understand the underlying problems in these patients. So it's not only a solution for giving a clue about what is happening to the patient, but it's also useful for telling to us if our treatment is the right treatment or not.
That's fantastic. Ignacio, thank you so much for taking the time out. And you did a fabulous job of explaining all that. Good luck in everything that you're doing out there on the front lines. Thank you for everything that you're doing.
Thank you.
And
a pleasure.
Take care.
Top Med Talk.
Thanks for listening. You can find us at topmedtalk.com. You can find us on social media. We are going to continue our awesome conversation. So thanks again for listening, and we will catch you next time.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.